Hi everybody, we're going to now talk about enteral fluids. Ooh, here's a mess. Okay, let's get started from the beginning here. Alright, so we're going to talk about some nutritional support. We're not going to go over vitamins in this particular PowerPoint, but we are going to talk about TPN, total parenteral nutrition, and enteral feedings. So we will get started on that. So there's three different types of ways that you can eat. So different types of feedings. There's oral feeding. So at that point, remember the last exam, there was a question, can the patient swallow? That's the first thing you need to find out, because if they can't swallow, then you can't feed them orally or give them pills. Also oral nutritional supplements. So anything that you take by mouth. Now the difference between enteral and parenteral is, think of parenteral as your IV, central line, any kind of line going directly into the vein. And enteral nutrition is going to the GI tract, but in a different way, either an NG tube down the nose, or they can have a gastric tube, which is a tube that is in the stomach area. So those are the most common ones. So if we look on this next slide, you can see that enteral nutrition, which we'll talk about first, there's two different ways. There's short term and then there's long term. So someone that needs it short term would be somebody that had a colectomy, which means part of their colon removed. Sometimes alcoholics can come in, or an acute illness, sometimes severe diverticulitis. They need to let the bowels heal, so they don't want any gastric secretions to go into the bowel. They need it to heal, so they'll put an NG tube down for a short time. So here is just a picture here that gives you an example. There's a gastric and duodenal tube. That just means how far the tube is going to go down. Usually it's an NG tube we see, and you guys will learn that. And now long term, which could be paraplegics, multiple chronic issues, just unable to eat anymore, elderly people that are do not resuscitate perhaps and are unable to eat, they aspirate, will have possibly a G tube, and that's put right into the stomach area. There is also a tube that goes into the jejunum, that's part of the small intestine, and you can see the picture there that it's there. Most commonly we'll see the gastrostomy tubes, and so it just goes right into the stomach. So what do we put in those tubes that's in the NG tube or the G tube? So there's different kind of solutions that you could put in. So most of the solutions, or formulas I should say, that you're going to put in are usually protein formulas, because you need that for healing. It does also have some nutrients in it. And these are for patients with normal GI function. So there's proteins, there's also some blenderized formulas that you can put pureed meat, vegetables, milk. Some people will make it at home. Usually you'll see these commercial ones right here. So this is just some formula categories, and it's called polymeric, which just means that it's more protein based. And here's some other ideas too. So as far as what kind of formulas, there's three different types. So modular formulas, it's your mixture of protein, glucose, polymers, lipids, which is like fats, and it's usually commercial based, so made commercially. The elemental one, monomeric, I think mono is being like simple. Think of that as it's already pre-digested nutrients, so they're much easier to absorb. So people that have a lot of issues with stomach aches, nausea, vomiting, diarrhea, elderly people that maybe they have had a colectomy and don't have a lot of colon left, you can use those pre-digested nutrients. And then there's some other specialty which have a mixture of a whole bunch of things in it. And here's just a picture of some of the methods of delivery that you can do. So you can see the kids, they maybe have cancer, and they've been going through like long-term chemotherapy, and they're not eating. Sometimes they'll go ahead and put the G tube in until they're all healed up, and then they'll end up taking that out. It's usually for longer term, and then you can see the girl with the NG tube in the hospital. It's more for short-term issues. All right, so what are the safety issues with this? So let's go back here. As you can see, the pump on the right side. So it's usually infused through a pump like that at so many cc's an hour, which we're going to learn that I think this semester towards the end, or possibly in APN 2, on how to transfuse or infuse it. But there's some important issues for this. Now, you have to think of it as you're giving them food. You're putting them food right in your stomach. So look at the little girl sitting in the chair. She's sitting upright. You want to make sure they're sitting up. Now, it looks a little deceiving with the boy, but he really should be sitting up at least 30 degrees. So make sure the head of the bed up is at least 30 degrees, because remember that aspiration. You don't aspiration, meaning the contents will come back up and go back into the lungs, and that actually can be life-threatening. So patient position. Make sure that they have some good bowel sounds. The last thing you want to do is put a tube feeding through someone that has a bowel obstruction. You also want to check gastric residual. So just make sure that tube is in the stomach. Everybody should have gastric residual. If obviously you pull back a whole entire huge syringe of formula, why is it sitting in there? That's something that you'll have to address. It should have been digested at that point if you're putting another can into tube feed. Usually tube feeds are done intermittently during the day, turn off at night, or vice versa. It just depends. Some go 4 hours and then they'll be off, and then, or some people just do the meals, or there's bolus. Bolus means that you'll give it with a big syringe for breakfast of stuff, and then lunch, and then dinner. So it just depends. Anytime you put in an NG tube, you always want to check and make sure that it's in the site. There's different agency policies, such as X-ray, and making sure the tube is in the stomach and not in the lung. Usually if it's in the lung, you will know right away if it's in the lung. They will let you know. They can't breathe, basically. So, all right, so these are some of the common mistakes. So look at this tube. It looks kind of ugly, doesn't it? It looks actually, to me, that it's very clogged up. So you want to make sure that, number one, you are flushing it with at least 15 to 30 cc's after you're done using it and prior to using it. Usually there will be an order for that to flush, but what happens if you don't flush? The stuff is going to get stuck in there and hard. And that's what you can see. And then it can get so clogged up that they need to replace the entire tube because you can't get it unclogged. There is an old method that used to be done years ago to put Coca-Cola through it. Most hospitals won't let you do that anymore because that's been known to, break all that up. So just be careful that you always want to look at the site too. So if you see around the site here, it looks okay. It's maybe a little bit red, but that's stuff that you want to document. And so you just want to make sure it's clean around the area. Sometimes they put like a little gauze in here with a little split in the middle. So this tube definitely does not look very good. When you're mixing medications, number one, you want to make sure that it can be crushed, because we talked about in class how with potassium pills that you cannot crush them. You can dissolve them very carefully, but you cannot crush them. So any type of medications, you have to make sure with pharmacy that it's crushable. Can it be dissolved in water? So what is the correct way that you can take it? Every medication should be done separately. So when you go into clinicals, you probably will see things that really aren't supposed to be done, such as taking all the pills at once and throwing it in like a container and then crushing them all up. You're really not supposed to do that together. It's supposed to be done separately. And then we talked about flushing the tube to get it through, because if you have to give some account to the tube length too. So if you just put the medicine through and then don't flush it afterwards, that medicine's probably sitting in that tube, and then it's not going to do any good because it's not going to get into the patient's circulation and do what it needs to do, and it's also going to clog up the tube. So as far as nursing process, we already went through this, but let's go through each each part. So your assessment is you're confirming that it's in place before you're going to give it. And you're going to listen for bowel sounds to make sure they have bowel sounds. That's your assessment. You're assessing the patient. Other things in the assessment, how are you feeling? Are you nauseated? Have they been vomiting and that kind of thing? So we've been through assessment portion before. Your nursing diagnoses. So fluid volume, deficient related to inadequate fluid intake or excess fluid loss. So it just depends. Why do they have the NG tube? And also a diagnosis could be diarrhea related to enteral feedings. So there's something called dumping syndrome. And dumping syndrome they can get if you're giving the tube feedings too fast. So that is what they'll have, a lot of diarrhea. So you have to slow down the rate of that. So you have to watch for it. So that would be a nursing diagnosis if this patient all of a sudden has diarrhea, a lot of nausea. It's called dumping syndrome. Think of it as like it's just you have too much going in and it's dumping all that fluid down. It's not able to digest. The nutrients aren't able to absorb like it should, so you're just having diarrhea. The key thing is slow down the rate. So remember, your planning is your goal setting. So what are we going to plan? The patient will not aspirate during enteral feeding. So that would be a goal for anybody with a G-tube or an NG tube. And the patient will receive adequate nutritional support through enteral feedings. So again, we want to watch for, is the head of the bed up 30 degrees? Are they getting it at the right rate? And remember your 5 rights to medications. It's same with this. It's 5 plus 5. Remember the 5 plus 5 rights. So if you don't remember, go back to that. Nursing intervention. So now you're going to check the tube placement. You're going to check the gastric residual, and usually it's around 30 to 40 cc's, which is normal. If you start getting higher, you kind of want to be concerned. Why is there still stuff in the stomach? It depends when they had their tube feedings last, but usually, and it should not be pure feeding. You should get some actually gastric secretions, which may be a variety in color, like greenish or clear, that kind of thing. And make sure the head of the bed is raised, and then you're going to evaluate. Remember evaluation. How are you doing? Now we're going to go to TPN, and you can see a picture here. This is someone obviously that needs TPN, anorexia nervosa, someone that's really malnourished. Also, there's people that are really ill, say with cancer, and so they're malnourished, and so they need some TPN. Someone that's had, say, a colectomy again, that is in the hospital for long term and just not getting nutrition any other way, so they end up doing it through central line. It does not come without risks, though. So it seems like it'd be so easy. Let's give them fluid through the central line, which I tell you, you should never give TPN through just a regular peripheral IV site. They have to have a central line of some sort, whether it's in the neck or whether it's in the subclavian vein. So just keep that in mind. They also need a larger bore IV for that to go through. TPN contains nutrients that we all need, which would be your carbohydrates, fats, and proteins, some amino acid, electrolytes, water. Also, I want you to keep in mind that there's insulin in TPN also that keeps your blood sugar where it should be. But again, as I said before, there's some complications. So remember when I just mentioned that they put insulin in that. So you never, you always want to be on top of the TPN. If the TPN is running out, if it has like 150 cc's left or 100, you want to make sure that you have that next bottle ready, because you don't want to stop it abruptly, because it can quickly have a hypoglycemic reaction. Because remember, there's insulin going in it already, and then you discontinue it and they haven't had any food, boom, they can bottom out. They can also be hyperglycemic because maybe they're not getting enough insulin, maybe they're diabetic, so it's just not enough, so it's a balance. So anybody that's on TPN, you want to check their blood sugars, so that should be ordered. There's also a risk for air embolism, getting in through the subclavian vein or wherever the IV is. Pneumothorax is when your lung collapses. Infections, maybe they're getting too much of it, so hypervolemia. So the one thing I want you to really be sure of, though, is the hypoglycemia, because that can be really dangerous. So let's talk about the nursing process. So you want to make sure what their baseline weight is, because you need to weigh them daily and see what their lab results are. Because with TPN, you want to check labs every day and want to make sure that their electrolytes are where they should be. If they're altered, then some things may need to be altered in the bag of TPN. So it's really more of a control environment with this, as you every day would check their weight, you check, you do a head-to-toe assessment on them, but also check their labs, and then make adjustments based on that. So the nursing diagnosis will be nutrition, imbalance related to altered nutritional support, could be infection related to TPN solution due to high glucose concentration. So they put a lot of glucose in there, which is why they add the little bit of insulin in there. Now planning, what's your goals? The patient's needs will be met via TPN, and then we will avoid infection. Your interventions, you're going to compare your lab results, check for signs of overhydration, fluid volume overload, third spacing, edema, and then we're going to do the evaluation. Okay, and that's it on this one.